Today we will try to cover this topic of perioperative control of diabetes mellitus. Um, Diabetes is one of the most common disease which anesthetists encounter, and actually there are so many confusion about how to where from where to read and what to know and what are the pearls about this topic. So I will just try to tell the basic points. Just a second, please. Okay. The first thing which you should be knowing about uh, this topic is that, can you see the screen? Yes. What are the main targets? Like, first of all, of course, you have to see whether the surgery is urgent or elective. Okay. And the first thing you should be targeting is, for example, if it is urgent, of course, you just have to do the stratification and you have to proceed. But if it is elective surgery, uh, what you need to do, check the blood sugar levels. Okay. And you should be doing HbA1c. Okay. And only by that you can say, and then of course the any risk factors associated with due to the macrovascular and microvascular complications. Okay. So that will be, so regarding this blood sugar control, you will be looking at the blood sugar levels and HbA1c. Okay. So there will be two group of patients. One will be taking oral hypoglycemics. Okay. And the other will be taking insulin. Okay. Among the insulin, one will be like majority people of on chronic management. If they are taking insulin, they will be taking some long acting for insulin, long acting. Okay. Or an intermediate acting like NPH or the regular insulin. Okay. So the common pathway will be that you will be converting all these groups into usually regular insulin. Can you just mute your mic, please? Please mute yourself. I'm unable to mute. Okay, so in some parts there is ultra short acting for insulin. This is ultra short acting, which is, what is the name of this? Lispro. Okay. So, but you can, because it's not available in everywhere. So you think that whether the patient is taking oral hypoglycemics or any preparation of insulin, that will be converted usually into regular insulin. Okay. And then what factor will be deciding? Mamuna, now you are here. So just try to participate. Uh, like, what will you be looking at? And Dr. Mamuna, can you? Yes. Walaikum assalam. So on which factor you will be deciding how to control the insulin, like how what you should be doing? How will you look at it?
I think so. You are asking me that which insulin I will give to the which patient?
No, this like, for example, you will be giving how much dose of insulin, or So
Are we
is there
talking about the perioperative?
any factor which will be deciding what you will be doing?
Yes, sir. It will include the patient condition at the time of diagnosis of diabetes, or are we managing it perioperatively,
No, no, we are
or
talking.
it is just an OPD?
Just a second. Let me rephrase. As an anesthetist, you are actually not concerned with the OPD management. Okay. When we are talking about anyone who is asking you, it actually is the perioperative. We are concentrating. I will have to remove this person. I don't know who.
Okay. तो सर
I'm sorry.
इसके अंदर यही है कि
This is just a second, Mamuna. You will be looking at the surgical risk. Okay. And
अच्छा,
how many meals patient is going to miss. Okay. And of course, what are the preoperative blood sugar levels. Okay.
okay.
Because what you are talking is the actually OPD management, and this is not our domain actually. Okay. This is beyond our domain. Yes, people ask it, but they will be asking you what medications a patient is taking. Okay. So I'm just trying to tell the things which are actually more important, not only in the clinical practice, but also in the exam. Actually, they ask the other question, but they don't fail on that question. They fail on this question, but people don't understand. They think that that thing is more important about the preparations and how much is the doses, because these are also being asked in our exam. Okay. So you will be focusing on as I told you, that if it is because for example the patient will remain NPO, you convert the patient post operatively on oral hypoglycemics?
Yes, sir.
No,
After when the patient will shift from the recovery to the ward area, but
no,
immediate post-op में oral glycemics नहीं देते थी.
no, no. We will You will be giving, you will be continuing insulin. I'm talking, for example, specifically laparotomy. Okay. Patient has underwent laparotomy, and now like intestinal surgery, for example. Okay. So can you start oral hypoglycemics here?
No, sir.
Okay. So you will be continuing on the insulin. That's what I'm trying to tell you. Okay. And for example, how much is the surgical risk? This is also a factor, and the type of the surgery. So the you will be continuing insulin in that period. So that is the domain. Okay. So what is oral hypoglycemics? You will be stopping. I'm just telling the basic principles. After that, you can we there will be so many things which we can discuss. We will be stopping oral hypoglycemics. Okay. And we will be doing the fasting blood sugar on the morning of surgery. Okay. Similarly, if it is long acting insulin, you will convert into regular insulin. Okay. Night before surgery, you will not give, for example, if the patient is taking long acting insulin at night, for example, you will not give. Okay. You will convert it into regular insulin. You will be doing the fasting blood sugar. And if it is more than how much, what is the limit for it? Do you know about it? If it is more than 10 millimole or more than 180 milligram per DL, you will be giving half dose of insulin. Okay. And if it is less than 10, you will omit. Any disagreement?
No, sir.
Okay. So just a second. So now other question is that how will you give? Whether you give subcutaneous versus IV, and in IV bolus versus infusion. So how will you rate these three things? Because there will be three ways to give it. Am I right? Yes, please. Like for example, you said that the blood sugar was, I'm sorry, blood sugar was 200. What will you do? Preoperative blood sugar was 200. Yes, Tayyab. Anyone wants to participate? Participate? Yes, Mamuna, can you hear me?
जी सर, इसमें ये
We have
इलेक्ट्रॉट
tried
वाले
to,
पेशेंट का डिस्कस हो रहा है,
we
200
because
ब्लड
we
शुगर है तो
just a second, Mamuna, we have some international speakers, so try to communicate in English.
सॉरी,
Try to communicate in
हेलो,
English, okay?
okay sir, sorry. So sir, are we discussing the same patient with planned for laparotomy
You know,
connected during
this just a second. I think there is some connectivity issue. Yes, I'm saying that just concentrate or basic, forget about laparotomy. Just tell me if you have a patient in preoperative period with blood sugar of 200 milligram, what will you be doing in the preoperative period? Would you like to give insulin or no? Or if you want to give, how much will you give? And which route?
I will first of all I will confirm that did the patient already had insulin routine insulin, if the patient already had taken like subcut insulin with whatever he or
No,
she
no, we are
takes
talking about the
in
same.
routine, so I will wait.
Mamuna, we are talking about the same insulin with the preoperative. That you are the perioperative physician. The ward is asking you, would you like to give insulin or no?
I will give insulin half dose,
How much? Like how
half
will
dose,
you
and
give
then recheck
subcutaneous? Will
if
you give subcutaneous? Will you give a bolus, IV bolus, or will you give an infusion?
I will I will confirm that how much time is remaining in the surgery. If the surgery is like in 1 to 2 hours, I will give IV bolus and recheck after 1 hour.
IV
And
bolus.
accordingly, I will start with insulin infusion if it
Okay.
will be required.
Okay. So how much units will you give in this? In this, for example, 200. How much units you will give?
I will give with zero point 0.1 unit per kg IV stat
0.1 units per kg.
unit IV
So
stat.
how much, for example,
Uh,
if it is 100 kg, you will give 10 units?
no, I will give 5 units because
No,
1 unit dilute
it's
25
it's
milligram per
if you give,
deciliter.
so if it is, for example, if you give like this 25 multiplied by 5, so you will bring the blood sugar to 75. No, it's not
5
like that. Okay, you
No,
are
no,
mixing
I'm
it up
wrong.
with, you are mixing it up with the decay. Okay, this is what
Yes.
we do in decay, and even that one we give, no, don't give in bolus, we give in hour. These units per hour we give, 0.1 units per kg per hour. We don't give in bolus. Okay, so in this usually there are so many formulas, but usually 200, for example, blood sugar divided by 150. So you can say around 1 unit. 1 unit you will give IV if you want to give a bolus. Okay, and subcutaneous versus IV, preferable is IV. Okay, and bolus versus infusion, the better is infusion. Okay, so the basic principle is that you will be giving you will be doing the fasting blood sugar and you will be using this. You say it's sliding scale. Okay. And in intraoperative period, what you will be doing? You will checking the blood sugar 30 to 60 minutes. Okay. And now either you can again give a bolus. Okay. 2 to 4 hourly. How much is the half-life of insulin? How much is half-life of insulin?
So 30 to 60 minutes होती है.
Yes.
30 to 60 minutes of regular.
In which route? IV, subcutaneous, or infusion? Actually, this is a tricky question. Okay. If you give a bolus,
Subcutaneous.
yeah. So it will be depending on, because subcutaneous route is not preferable in perioperative period, because the absorption may be unpredictable, especially in the intraoperative period. Okay. So, so the better way to answer this question is that you will be checking the serial blood sugars. Okay. And what is your target blood sugar? How much blood sugar you want to maintain?
110 to 100 mg per deciliter.
No, it's not always a strict one. According to NICE guidelines, you have to maintain sugar between 80 to 180.
No.
No. It's still, this is not
Listen,
recommended now.
Listen, there is a tight control, tight glycemic control, and there is a loose glycemic control. Okay. So which is better?
Sir, loose.
So loose, and loose is less than 180. You have to keep it around 120 to 150. Because you know what you do, if for example blood sugar is 70, what you do? You give dextrose actually. Okay. So you will never try to reach on the lower side. Less than 100 is never recommended. You should be keeping it at least more than 100, and preferably around this level. And another thing is that because these things are not written in the books, but actually these are more important things clinically as well as in the exam point of view. Because that insulin requirement will be, what about insulin requirement? It will be according to the stress. Okay. And in the earlier part of the surgery, the requirement will be more. Okay. And later on, as the surgery is progressing towards the end, the requirement may be decreased. Okay. So you have to think about these things. And then what in addition to blood sugar level, would you like to do any other thing when you are giving insulin?
Yes, potassium.
Electrolytes overall. Okay. Especially potassium. And you should be taking care of hypoglycemia. Okay. Because if you give insulin and this one patient become hypoglycemic, hypoglycemia is a serious consequence as compared to hyperglycemia. What will happen if patient remain hyperglycemic? What can be the perioperative problems if you don't control the blood sugar? What can happen?
Delay wound healing,
Delay
infection.
wound healing. Okay.
Infection.
You are telling the surgeon's point perspective.
Sir, the patient can go into honk, decay.
Yes. So I think that is, if we try not to reproduce the books, that is the better
Osmotic,
answer.
yes.
Dehydration.
Yes, osmotic diuresis. Yes, it can lead to the dehydration, even perioperative myocardial ischemia, and
Like
due to dehydration, of course,
I
there
will
can be
be very happy if you use this word, that impaired blood sugar levels are associated with unwanted or what you say adverse perioperative, myocardial events. Okay. So just, yes, of course, your answer is correct. Wound healing and infections, and this is all, but you should be telling the things which are related to you. Okay. So I have just given you, again, I will just repeat, because these things, if you don't forget, you will never fail. I guarantee you this thing, that you have to convert the oral hypoglycemics and long acting into regular one. You will be checking the fasting blood sugar, and you will be giving the dose accordingly. Intraoperatively, you will be checking the blood sugar 30 to 60 minutes. Preferable route will be IV infusion. You can give bolus as well, but it is better to give IV infusion, because there will be no brisk change in the blood sugar. Okay. And you should be looking at the signs of hypoglycemia, which may be masked intraoperatively. So this is how you should be focusing. Now that they, because we are confused, in every book you will find different regime. Okay. So that is very confusing. Am I right? So what regime would you like to use intraoperatively?
So there are several regimes: VRRI regime, sliding scale, Alberti regime. You can remember
Okay.
one of it.
So what about this VRR?
VRRI.
Yes. How will you explain it?
So different hospitals have different protocols regarding VRRI. Every hospital has its own.
Okay, like, for example, give just one example.
No.
Like, for example, have you heard about preform mixture with insulin, dextrose, and
Yes, sir. You are talking about Alberti regimes. Yes, in
no,
100
no, no,
milligram,
no,
we
no, that is no. Actually, Alberti regime is buried only in the dark lines of books. I don't think so anyone in the world is using this terrible regime now.
still our examiners ask about
They,
this.
with due respect, actually, this is not correct thing. Okay, what they are getting. Anyways, I'm being asked by my teacher, don't criticize anyone. So I will try to control myself. Anyways, but GIK regime or this Alberti regime, I'm sorry, I'm not. It's a
We
terrible
don't
regime.
know. We don't know this Alberti regime in our sector, and seriously, I don't know about it. And I will
But
never ever try
you
to
should be,
memorize it.
if anyone knows about it, just tell, because this is a very frequently asked exam question. If you know it, please tell. Who used the word this? Yes, please tell if you know.
Yes, I'm gonna tell.
Actually, it is a combination. If I'm not wrong, they make up solutions with dextrose water and potassium. They're the same thing which I am
Yes, sir.
telling you.
Yes, sir. Dextrose, potassium, and insulin, and we give it in an infusion form. And according, we check the BSR levels. I think
And
1 hourly, and we adjust the infusion rate according to that.
no. This is not Alberti regime. This is actually, in this one, they put certain units of insulin in the drip. Okay. And actually
Actually, it's
they
written in
start.
Oxford. Let me check it. It's written in Oxford. Let me check it.
Okay, so the common thing which you can explain is that there is, in some setups, there is a combination in one, and they have written that if it is blood sugar is between 6 to 8, for example, you have to continue it at 30 to 40 ml. Like, I'm just giving you example, ml per hour. Okay. If it is 8 to 10, it is 50 to 80 ml per hour. So things like that. It is according to the rate. They have just pasted a scheme over it. Okay. Or another is that you can make equal volumes in like in insulin with normal saline. Okay. You like, please mute yourself. This is not good. Please mute yourself. Everyone is being disturbed. Equal insulin volume in normal saline, for example, 50 units in 50 ml, and you do 30 minutes to 60 minutes, okay, and then you control accordingly, okay. You can use this formula: blood sugar level divided by 150. So for example, if it is, for example, 300, so you will be giving 2 units per hour, okay, and you will adjust the rate 30 to 60 minutes. You will be adjusting it. This is one way. Or other way, actually in good hospitals now they prepare like this. I will try to show a scheme for it, okay. So you have to do the you have to adjust also the electrolytes. You will be replacing potassium. You can, if you are giving, for example, and another question in actually it's not the part of it, but what about ringer lactate versus normal saline as maintenance, as fluid for diabetic patient? What is the problem with ringer lactate? Is there any contraindication in giving ringer lactate? Yes, Mamuna?
No, there is no difference between ringer lactate and normal saline. It was like thought like ringer causes hyperglycemia and we should use normal saline, but normal saline causes acidosis, metabolic acidosis. There is no difference between the use in the
Yes,
ringer
Only
lactate
in
or
DK
lactate.
normal saline is used. Rest
Only
we
yes.
can use regulated.
Actually, normal, and we will discuss that one as well. Actually, the name normal saline should be changed with abnormal saline. Actually, it's not at all normal. The blood, the sodium is 154. Okay, the chloride is 154. So it's a terrible solution. Yeah, unless patient is in shock, I don't think so. Any indication to give ringer like a normal saline. Normal saline is not at all a good fluid, believe me. Yes, in shock, when you want to increase the blood volume immediately, because it's relatively like sodium is more, so volume will be increased more. Okay, so otherwise,
Yes, and pyloric stenosis also.
that one, what you said, that in DK you use it. DK in normal saline you use to correct dehydration. Okay, and once you get the this one urine output, then you can. And another thing is that there is two solutions in it. One is maintenance, okay, and one is replacement or dehydration. So in this condition, normal saline may be a replacement fluid, but maintenance may be ringer lactate or maybe dextrose saline, half dextrose saline. Okay, this is in with reference to the pediatric population. Okay, so I will just show you what was. Okay, these questions they can ask you that what are the neuroendocrine stress response to surgery? Okay, so only insulin level are decreased and there is resistance actually more than. So these are the factors which are actually increasing the blood sugar levels, like cortisol, insulin resistance, increased hepatic breakdown of glycogen, increased gluconeogenesis, impaired pancreatic insulin secretion, increased fat and protein catabolism. These are the reason. Okay, and this is what I was telling you. Wound healing and increased perioperative myocardial infarction, worsen neurological outcomes. Yes, I did not mention this thing. Neurological outcome are especially with reference to head injury or anything like that. For example, if you have going on this cabbage, and if the patient is really hyperglycemic, so it will affect the it will affect the this one neurological outcome. Okay, so similarly, hypoglycemia is more dangerous than hyperglycemia. Actually, in acutely, there will be more effect with hypoglycemia, because if patient become hypoglycemic, there may be irreversible damage to the brain tissue. Okay, so this is then we discuss about this types of insulin. I will just come back just a second. What is insulin? What type of hormone it is? Is a peptide?
It's a polypeptide. Polypeptide.
Yes. Yes. Okay.
And
So
it has
and
catabolic as well as an anabolic activity, both.
catabolic? No, anti-catabolic. It is
So both
anti-catabolic.
effects.
No.
Insulin is anabolic hormone.
Insulin is anabolic hormone. And it is anti-catabolic. Okay. It is anabolic and anti-catabolic.
Okay, but I think so. I have read somewhere it has some
No.
catabolic activity.
No.
Okay.
Remember one thing: if something is it is this was discussed, like it is against the basic concept, you have to reconfirm it. Okay.
Well, basically, it is anabolic. Yes,
Yes, anabolic and anti-catabolic. I'm again
anti-catabolic. Okay.
anti-catabolic. It is
Okay.
inhibiting the catabolism, because if you will use this word in the exam, they will fail you. Okay, that's why I'm telling you again, all of you who are preparing for the oral exam, remember one thing: don't utter a word which you cannot explain. Okay, don't utter a word even if you have any doubt in speaking out this anti-catabolic. Anabolic, if you say, it's enough. Nobody will fail you. If you don't, even if you don't say anti-catabolic, this is a second thing. But anabolic, in place of anabolic, if you say, and it has both anabolic and catabolic, this is a blunder. Okay. Anyways, so they have presented in a different way preparations, and then this about this prandial and basal. Yes. What is about what do you mean by this prandial insulin?
खाने के साथ.
Yes, it is related to the increased response which occur after the meals. Okay. So biochemical structure, then rapid acting, short acting, intermediate acting, and long acting. Okay. In long acting, you can remember this name, this insulin glargine. Okay. NPH is the milky insulin, which is intermediate acting. Okay. And this is a very good way to understand. Thanks God that I don't have to appear in the exam again. And these things were not there when I actually appeared in the exam. But actually, when I see them, I say that these things are very easy to remember and you will not forget it. You see, you can say that the peak is occurring immediately within, this is hours, and this is the insulin levels. Okay. So it is coming fast and going down fast. It is going down relatively, coming down relatively as compared to, this is actually what I was telling you, ultra short acting. So they are coming very fast, and they are coming, their effect is finishing earlier. Okay, then comes this regular, then is NPH. I have not heard about this detamere. I don't know what is it. Glargine, it's a long acting. Okay. Memuna, for you, for or people who are preparing for the long cases, or even the residents, I will suggest you to understand this thing, and from because during the training, if you understand this thing, it will become very easy for you to understand. Okay, so you can have as I have discussed, this is, you can have a look on it. Okay. Okay. Patients require a constant source of insulin, whether or not they are diabetic, or discontinuing or decreasing insulin for fear of hypoglycemia is not appropriate. While insulin inhibits both gluconeogenesis and conversion of glycogen to glucose, it also inhibits degradation of fats to fatty acid and of fatty acid to ketones. Inadequate insulin dose can lead to uncontrolled hyperglycemia and can even cause ketoacidosis. I have told you the pearl, which is the more important thing. Some person was mentioning nice, so it is less than 180, as I was telling you. Okay, and this one you were telling, you see that that's why sometimes it becomes confusing. They have see that if you are controlling 80 to 180, there are more mortality. So they are saying that if they are controlling in less than 180, there is less mortality as compared to if it is 80 to 110. Okay, so that's what I was telling you. There is not fix. If you forget, don't try to be confused with the number. In some book you are finding 120 to 150, somewhere you are finding the basic principle is that you don't let the blood sugar less than 100, simple as that, and you should not let it more than 180. This is the basic principle. Okay, please, I don't know why people don't understand. Please mute yourself. It's disturbing for everyone. Whosoever wants to speak out, everyone of you are welcome. Okay. Okay. So yes, Mamuna.
So basically, physiologically, it is happening like there is constant irrespective of meal intake. Yeah, if I'm not wrong. And
I'm
the
sorry,
insulin
your
basically doing
voice,
all these things.
Mamuna, just try to
Uh,
change your position. Your voice is distorted. We couldn't hear you. Please try speak again.
sorry, sorry. I was saying that the concept basic physiological concept is also the same, that with irrespective of meal intake, there is basically the production, constant production of insulin, like 1 unit per hour, which is doing all these things, other activities like prevention of breakdown of lipids and
This is the
glycogen.
normal physiological
I think
mechanism.
so.
Yes, that's why if it
Yes,
is
yes, and when the patient, yes, when the patient takes some meal, a patient or anyone, a normal person takes the meal, then there is the surge of insulin. If I'm not wrong, that's why we
yes,
give the that prandial insulin to the diabetics, because they don't
yes,
can
they
manage
cannot
that.
adjust their mechanism, their feedback mechanism, their auto regulation is impaired. That's why
Yes.
they
We
become
give
like
the, that's why we, yes, that's why we give the insulin, even when the patient is fasting, and even the DK is recovering, and we don't suddenly stop the insulin when we are
yes, yes, yes.
managing
We don't
DK
have to
or
stop the
like severe
insulin.
hyperglycemia.
Yes, yes.
Yes.
Okay. So that's what I was telling you, that discontinue the premix insulin and switch to a regimen that includes long acting. This is actually too much details. You don't need all of these to be reproduced. Simple. Try to be very simple. Stop in long acting or intermediate acting. Convert into regular insulin. Nobody will fail you on this thing. But if you try to reproduce the whole of the article, believe me, you can be stuck, because I don't know, this is even surprise for me as well what they have written here. This can be done by substituting a long in place of the night dose time dose of 70/30, a quick formula. I don't think so it is required. Nobody will ask you. Okay, simple. You have to be very simple. Okay. I think this seems interesting. Correction factor 1800 divided by total daily insulin dose. What is it? Actually, I have not read this article. I'm just trying to show you, if because whatever basic concept is there, I just try to use that concept. Okay, I think leave it. And similarly, the basic another important thing is that you have to gradually the insulin requirement will be decreased, but you don't have to discontinue urgently. You will start oral hypoglycemic and then you will stop it. Okay, because oral hypoglycemic even will take some time for its effect. Okay, so the remaining part which is there is the diabetic Okay. So another thing which I want to tell, because we started a little late, I will just try to tell the basic principles again. What are different oral hypoglycemics? What is the basic types? One is insulin saligo. Okay.
Yes, increase the sensitivity.
And
We have
increase,
sulfonylureas.
yes, increase sensitivity. Okay. And another is the decrease absorption of
Glucose.
glucose.
Glucose in gut.
Okay, so basically if you just understand this thing, so these the ones who are increasing the insulin secretion will cause hypoglycemia. Okay, so all like this sulfonylureas, and there are, because I don't remember the names of these new groups, I will just show you the slides. Okay, so and the basic this biguanides. Okay, it will cause, biguanides will cause
Increase sensitivity.
so, but it does not cause hypoglycemia. Okay, it does not cause hypoglycemia. The main side effect of biguanide is
Lactic acidosis.
lactic acidosis. Okay, so this is the basic. If you know this thing, you will not fail. The rest of the things are additional. Understand? If you know the, because sometimes we try to learn everything and we become confused. So I am just trying to give you an outlook that what are the failure points we should not miss. Okay, just a second. Even then you will find a lot of things here. Just a second. If you want to have a good concept, you have time, this residents, I will highly suggest you people to, because this is a topic which is the pearl of anesthesia. You should be knowing as much as possible. Okay, so we talked about the sulfonylureas. Okay, so meglid, even I am not able to pronunciate nicely. Meglitinides, short acting
Magnetides.
insulin. Okay, so this is new babies of sulfonylureas. Okay, so rapaglinide, I don't know which are available because I have not seen them. Then another group here. So you, if just,
Sitagliptin, sir, it's added in sitagliptin. It's a new antihypertensive, sitagliptin.
yes. So the basic this is that you try to memorize the names and try to fit it with either with sulfonylureas or bigonids. Then you will not be able to miss it. Okay. So this acarbose, this is also related to the perennial, because it is inhibiting the absorption of this one carbohydrates. Am I right? Okay. Okay. So what about this one? Sodium glucose transporter 2 inhibitors. What is the name for this one? I think this is also some new medication. Bigonids, which I was telling you. That this will not cause hypoglycemia. Okay, because that's why this metformin and they are used for other than diabetes. Okay, what are the common use for these things? Yes, please. What are other use than this one diabetes for this metformin?
Yeah, in PCOS for weight
PCOS,
reduction.
Gynecological.
In
yes, weight reduction. So this
polycystic
is,
ovary, yes, weight reduction.
yes. Okay. So this one thiazolidinediones. Okay. This is also in increasing the sensitivity of naturally released insulin. Okay. So okay. Actually, just try to have the basic knowledge, please. because even if they are asking you in the exam, it will be a very smaller part. If you try to read and learn everything, you will not be able to swallow. So try to learn the basic concept, which is avoiding you from failure. Okay. So any question, please? Because now I will just summarize what because this is a question that is being asked: how will you control the blood sugar? What will you do? What preparation will you give? So I just wanted to tell you the basic concept. The basic concept is that you have to target a specific blood sugar. You have to select a regime in which the basic principle is that you will be converting the oral or long acting into the regular or this short acting ones, and then you will be targeting the blood sugar. You will be checking the electrolytes. You can use IV or infusion or even subcutaneous is not predictable, so they say that it is better not to use subcutaneous. It is better to use IV in infusion or in boluses. So this is the basic principle. I think I don't know what has happened. Just a second, please. This is the just a second, I will. Actually, this is the guideline. You can have a quick look on it, and just a second. Similar things I was discussing. Just have a look on it. I have shared. I will share the link for this one as well. Any question, please? Yes, Mamuna, do you understand? So I think you will be able
Yes, sir.
to.
Yes, everything is very clear. Thank you so much. Just there is one thing is very confusing. Like
Yes.
if somebody asks, like you have to manage a patient, and patient is in the ward, and he's planned for lab cholecystectomy
Okay.
tomorrow.
Okay.
So and the blood sugar is like 200, 250. What you will do? So at that state, if patient is stable, like so should we say that I would like to rule out DK, or like patient is saying my normal blood sugar random is like 250 to
you know
300?
if I understand, I will tell you the smart answers. Thing is that number one, this question because in if you are talking about table viva, for one scenario they have only 4 to 5 minutes. So just imagine in this 4 to 5 minutes how much will be the component of this question or this answer. Okay, but because we don't have these smart points or smart answers written in the books, that's why you are become confused. Okay, so I will ask you that you will be using that. I will be evaluating the patient. Okay, I will be evaluating the patient on the basis of history, examination and investigation, and I will be ruling out any risk factors. Okay, so what thing will be designating you as DK? How can you say in 200 blood sugar, how can the patient will become in DK? What will be the things you will say that yes, now you can use say that I will try to rule out DK? In which conditions? The patient will be on insulin dependent diabetes. Am I right?
Yes, a young patient, type 1 diabetes.
No, even there is no no clear cut distinction. Even old age patient can go in DK.
Presentation,
Okay,
patient is
Yes, but in
because
exam they
is
give a
having
clear
active
cut
infection.
scenario.
yes, they give a
If
scenario. I will tell you something. How just a second, please. Your voice is distorted, Memuna. I will tell you that what is the basic difference between DKA and non-osmolar, non-ketotic hyperosmolar coma. What is difference? Main difference. Single word answer.
The presence
acidosis.
of ketone bodies.
No. What this is the result. But what is the reason? You are right. Your
Sir,
answer is correct.
absence of insulin.
Total
How
absence of
the
insulin.
difference acidosis?
Okay, because even if there is a small bit of insulin, it will prevent the ketogenesis. Okay. But if there is absolute deficiency of insulin, then decay will develop. And decay can develop in
Sorry, I
uh,
can.
type 2 diabetes as well. Okay. But it is more
There are other
common.
difference also in exam. They are asked about the differences between DK and hyperglycemic.
The blood sugar will be very high in non-ketotic as compared
Yes, there would
to.
be dehydration, hyperosmolarity, the absence of ketone bodies, the pH values. They are the main difference.
Yes, but usually the principle of management is what is the first thing? Is it the insulin, which is the first thing to tell, or dehydration? When you are talking about management of decay or hyperosmolar.
So the management is dehydration.
Yes. Okay. Even you don't start insulin in very high dose, or you will be correcting the blood, the dehydration. The more important thing is dehydration. Okay. So we will, I think tomorrow we will discuss these decay and hyperosmolar. Okay. So thank you very much for your presence. And
Sorry, sir. I just
yes,
reconnected. So you were saying you said the amount of insulin and end result. Basically, the acidosis is the hallmark of decay, right? Which is
ketone
differentiating
bodies.
point from Hong Kong.
No, no, ketone bodies.
Yeah, ketone bodies can be present in both.
No, no.
Ketoacidosis is in the decay, right?
Yes, ketoacidosis. So
Ketone body is only present in DK. This is the main difference.
main difference between decay and non. We will discuss tomorrow, inshallah. Okay.
Okay, okay.
Okay.
Thank you.
So in between the Viva candidates, please, I will suggesting you that create scenarios, or all of you are welcome to discuss any scenario. Okay. Because unfortunately in Ramadan, I couldn't conduct the sessions. Okay. So, but now you all are welcome. You can ask any question. Rather, if in the Viva group, if anyone wants to discuss any scenario, you all are welcome. Okay. So thank you very much. We will discuss the remaining part of these perioperative complications related to diabetes. So thank you very much. Bye bye.
Thank you, sir.